Good evening, and welcome to tonight's Men's Health webinar with Dr. Abe McBride. Tonight, we're going to cover the signs, symptoms, and treatment options for erectile dysfunction and stress urinary incontinence. You are welcome to ask questions anytime during the presentation on your mobile device, tablet, laptop, PC. Just find the chat feature. So move your mouse around, tap your screen, find that chat box, click on it, type your question in, hit submit, and we will answer those questions at the conclusion of the webinar. Without further delay, I'd like to introduce Dr. McBride.
Good evening, everybody. Abram McBride here. Thanks for attending. So this afternoon, we're going to talk about two topics that are very important in the men's health world, erectile dysfunction and stress urinary incontinence. So just a brief little introduction to me. I am a urologist in Colorado Springs. I did a fellowship at Baylor College of Medicine in Houston, Texas. Allowed me to specialize in men's health, and so really that's all that I do. I mean, I take call. I can do some general urology types of things, but pretty much my entire practice is erectile dysfunction, stress urinary incontinence in men, low testosterone, microsurgery, infertility, things like that. So these topics are very important to me because I see so many men with these issues. And so I think it's important to provide good education on these topics and the available treatment options, because there is a lot of mixed information out there from other clinics and providers that may make things a bit confusing. So first, we'll talk about erectile dysfunction. And what is erectile dysfunction? And essentially, it's defined as the inability to achieve or maintain an erection that's firm enough for sexual intercourse. And a lot of you probably know by now that this is actually quite common. Many men suffer from erectile dysfunction. In fact, approximately half of men over age 40 will have some degree of erectile dysfunction at some point in their lifetime, which is approximately 39 million men in total. So a lot of guys out there do have some symptoms of ED. But to understand erectile dysfunction, we have to first understand the normal erectile function. And so on the screen here, you see two pictures, and I'm not sure if you can see my mouse arrow, but on the left side, your left side of the screen is the penis in the not erect state. And in this cross section, you see two areas that are what we call the corpora cavernosa, which are the structures inside the penis that would normally fill with blood flow during an erection. And so you can see here now on the right side, after the patient has been stimulated, these spaces inside the penis, the corpora cavernosa, have now been filled with blood flow, the patient's natural blood flow, and an erection takes place. And then, of course, that is meant to last long enough for the patient to reach orgasm and typically for the partner as well. And of course, afterwards, the blood drains and the penis goes back to its normal resting state. So what are some different, what causes erectile dysfunction? I mean, obviously a lot of men have it. But when we look at this chart here, this sort of breaks it down. And really the most common cause is vascular disease. And vascular disease encompasses men who have had heart attacks, who have blockages in arteries in their hearts, or the main blood vessels that go through their neck to their brain, or other blood vessels in the body to the legs or the feet or things like that. So vascular disease is definitely the most common cause, but right behind that is diabetes. And really, we'll talk about this more in a few minutes, but diabetes and vascular disease do have a lot of overlap. But other than that, there are medication side effects that can cause erectile dysfunction, hormone deficiencies like low testosterone, and of course, pelvic surgery and trauma, where some of the structures that are necessary for normal erections can be damaged. But despite the diversity of these different causes of erectile dysfunction, I want everyone to realize that erectile dysfunction also has a very broad negative impact on quality of life. So this goes beyond just being an illness you take a medication for. It can affect your emotions, your mental health, things like that. So let's dig a little deeper into the connection between erectile dysfunction and diabetes. So diabetes is unfortunately fairly common. We know that about 15 million men in the United States do have diabetes. In those men with diabetes, the symptoms of erectile dysfunction could actually be the first indication of diabetes. And I've actually had a handful of patients over the years that have come to me with erectile dysfunction. And in part of the evaluation, we've done some blood work and discovered they have diabetes and they didn't realize it. And that's obviously hugely important to get ahead of that disease and get treatment for that started early on in the course of the disease. But men who have diabetes and erectile dysfunction, unfortunately, the symptoms of erectile dysfunction are more severe and more difficult to treat, and in general, less responsive to some of the standard typical treatment options. So why is diabetes so destructive to our normal erections as men? And really, there's two pathways. The first is the fact that, with stimulation, both visual stimulation and manual stimulation, our nerves carry those messages and those impulses to our brain, which leads to sexual arousal. And if those nerves are damaged, which we know a lot of men with diabetes do suffer some degree of neuropathy, which is damage to the normal nerves, that those signals are not transmitted as good as they should be. But also diabetes damages what's called endothelial cells, which are these specialized cells that help blood flow through very small blood vessels and throughout the entire body. And it's this combination of damage to nerves and small blood vessels that lead to men with diabetes having a lot of issues with, responding to sexual stimulation. For example, oral therapies, the pills for ED are less effective because you have to have sexual stimulation for those to work. And so it just makes treatment much more difficult. Now, switching gears just a bit, we'll look at erectile dysfunction and heart disease. And we know that heart disease is really important. I should say erectile dysfunction is really important in the development of heart disease. And in many men, ED can show up as a symptom, as a problem, several years before symptoms of heart disease can manifest. And so we think of this as, I may have a patient, again, I've had some patients where they come in, we're working through their symptoms of erectile dysfunction and working on that, figuring that out, and to have them go see a cardiologist, and lo and behold, they have a blockage in one of the arteries of their heart. And that can be detected early before it turns into a full-blown heart attack. And so erectile dysfunction in general is considered an early warning sign, or kind of like a canary in the coal mine type of example of being able to pick up heart disease down the road. So the reason for this is I think really interesting. If you look at this diagram, it shows these different circles, and on the far left of your screen is the smallest. And this represents the diameter of the penile artery, which is typically about 1 to 2 millimeters in diameter. And that's how wide the blood vessel is that carries blood flow into the penis. But when you compare that to the main arteries that carry blood flow into the heart here, the next size up, which is about 3 to 4 millimeters, the carotid artery, which carries blood flow up into the brain, 5 to 7 millimeters, and obviously the femoral artery. These other vessels are significantly larger. And when you have enough plaque buildup to occlude at least 50% or more of one of these larger vessels, you can imagine what happens when you have, plaque buildup in the penile artery. And so it does not take very much plaque buildup to block the artery that carries blood flow into the penis. And so that's why symptoms of erectile dysfunction may appear before, chest pain or a stroke or things like that, when these larger arteries become occluded from that plaque process. So how can you reduce your risk for heart disease and also erectile dysfunction? Because these two processes go hand in hand. And really, I tell everyone, what's healthy for your heart is healthy for your penis. And so eat a good diet. I usually tell folks to eat a Mediterranean type of diet or a plant-based type of diet. Physical exercise, get out there and exercise 3-4 times a week. Lose some weight, certainly quit smoking. That's never good for normal blood flow, and reduce stress. But obviously stress is sometimes woven into our daily life and not something we can necessarily just get rid of, but really just manage the stress better. So diabetes and heart disease, obviously, are the two most common causes of erectile dysfunction. And we've explained those relationships. Now let's kind of switch gears again and focus in on what are the different treatment options specifically for erectile dysfunction. And I'm sure a lot of you have heard of at least one or two of these, but we'll kind of review all of them, all the available options on the menu here. So you have oral medications, injections of medication into the penis, vacuum erection devices, urethral suppositories, and penile implants. So first we have the oral medications, Viagra, Cialis, Levitra, Stendra. These drugs have been around for well over 20 years. And essentially they're a pill that you take usually around the time that you and your partner want to engage in sexual activity or intercourse. And these medications do require you to have sexual stimulation. And so with these medicines in your system, when they're working, you and your partner are interacting and being intimate, and these medications will increase the blood flow into the penis in the hopes of achieving a more full, rigid erection that also lasts longer. They're pretty darn effective. I would say anywhere from 60 to 80% of men will typically have positive or at least partial results with these medications. But they do also have side effects, and I'm sure many of you have probably tried these already. You can get these medications pretty much anywhere, it seems, these days. But headache, facial flushing, nasal congestion, blurry vision, things like that can be a side effect. And there's, of course, certain medications that are heart-specific medications that you cannot take these oral medications with. But that's quite rare. In fact, I was thinking back the other day, I really have only found one or maybe two patients in the past year that had other medications that precluded them from being able to use Viagra or Cialis. So, but they can be effective. But remember, about half of men will report that at some point these either just stop working, or they don't like taking them, or they have too many side effects, and they'll move on to some other type of treatment. Next on our list of treatments, we have intracavernous injection therapy. So this is the injection of medication directly into the penis. And so this is something that the patient does or their partner does every time that you want to have sexual activity. You drop this blend of medications, usually it's called trimix, because there's three medications that are mixed together in this cocktail. And as you can see in the picture, you put the needle into the side of the penis and inject the medicine directly into the corpora cavernosa to increase blood flow. This therapy can definitely be effective. Anywhere from 80 to 90% of men will report getting a positive erection with this treatment. And this, important to note, this does not require sexual stimulation. And, in fact, I will use this in the office for diagnostic purposes to generate an erection for me to evaluate if there's a penile curvature or other deformity, or to do duplex ultrasonography to evaluate the blood flow characteristics, because this medicine is strong enough that the patient will have an erection in the office, completely not sexually aroused. So can be effective, but there's certainly side effects, obviously pain. When you inject this medicine, it can be uncomfortable, but there's also pain from the medicines working. And I tell folks that about 20-25% of patients will get what I call a penis migraine, because the blood vessels dilate so aggressively to get blood flow in that you get this achy discomfort in the penis as long as those medications are being active. But you can also get bruising. You could develop scar tissue from these injections. And I've seen patients who have been doing this type of therapy for a long time get these big nodules of scar tissue as a result. And mostly side effects, lack of spontaneity, inconvenience are reasons for discontinuation. Inconvenience is worth noting. I mean, these medicines can go with you. You can travel with them, but they have to stay cold. So you have to refrigerate them or carry a cold pack if you're flying. And so there's a few issues there that some patients, are okay with, but some patients don't like. And that's why they do not continue. Most patients, again, looking at the research, 25-30% of patients are still using these medications beyond 6 months. Next, we have the vacuum erection device. As you can see in the picture, this is essentially as simple as putting your penis into a tube, and the tube is either attached to some kind of battery-operated motor that creates negative pressure vacuum, or you can use like a little manual, like blood pressure cuff type mechanism. But either way, a vacuum is created, and it really stretches the penis out in length and girth, and tries to draw blood flow in to have an erection. And this can be quite effective at getting an erection, but the problem is as soon as you take the device off, the erection very quickly goes away. Some men will use like a constriction band or constriction ring in conjunction to try and pinch the base of the penis and trap that blood flow, so the erection can be maintained. It works okay. I've had patients give me mixed results, but I caution all my patients to be careful because that constriction band can be a bit traumatic and cause some scar tissue where it's used at the base of the penis. But in general, what I found is most people do not like these to be used for spontaneous sexual activity with a partner. Really, most men use these more for exercise, for stretching the penis and things like that. We also have urethral suppositories as an option. As it sounds, it's basically a medication that is compounded into a suppository type form, and you administer that down the urethra. And the urethra is the tube that you urinate through that comes out through the tip of the penis. And so in the picture, you can see an applicator is being used to deliver that suppository down to the urethra. It takes a few minutes for it to absorb, and that medication then induces pretty potent vasodilation of the arteries to enhance blood flow into the penis. I think the big thing to note with this is it's pretty uncomfortable, both uncomfortable to have something put down the urethra, but more so the medication has to absorb through the urethra and then beyond the urethra into the corpora cavernosa to be effective. And that is typically causes a lot of burning and achiness. But I have had a handful of patients who seem to be pretty happy with this as a treatment option. But like I said, the pain, discomfort, and inconvenience is why most men don't use it very, very much. I do want to give a brief bit of attention to what our American Urologic Association considers to be experimental or investigational treatments, extracorporeal shockwave therapy, or Gaines wave, or sound wave, or acoustic wave, or whatever wave you want to describe it as. Everyone has a different description for it. But also stem cell injections, as well as platelet-rich plasma injections. Now, the shockwave therapy, there is some good science and research behind that. It's actually in widespread usage throughout Europe. And it's just the United States, the clinical trials are a bit behind in terms of being enough research evidence for FDA approval. But in the right patient and the carefully selected patient, this therapy can be effective. But it's important to note that it's for the right patient. A lot of these clinics will advertise this as a sort of quote unquote cure-all therapy for everyone. And that's definitely not a realistic expectation. But when you get to stem cell therapy and platelet-rich plasma therapy, there's very little research to support dependable, reliable results with those therapies, and they're very much investigational. So moving past that, we also have as an option penile implants. Now, penile implants, some of you may or may not have heard of these. They've actually been around for over 40 years in various forms. And you can see here on the far right, we have the malleable implant, which was sort of the initial one that came out many years ago. We also have the two-piece inflatable implant, which is very rarely used. And then what the vast majority of what is utilized today, in 2022, I would say in my practice, at least 98, if not 99% of implants that are used is the three-piece inflatable penile implant. So what is a three-piece inflatable implant? What does all this mean? So in the picture, it's kind of small. We'll have a video here on the next slide to kind of give you some better illustration of this. But essentially, implants have a role when the blood flow system in the penis is no longer working or not working as well as we would hope. And so instead of using the patient's natural blood flow system inside those corpora cavernosa, those two mostly hollow spaces inside the penis, we have two cylinders that are placed in there, and you can kind of see these cylinders. And these cylinders are silicone-based material that are basically kind of like balloons. They're empty, but they can be filled with fluid. And there's a pump that is down in the scrotum, under the skin, of course, but in front of the testicles. And when the patient or their partner desires an erection, that pump can be squeezed and released, and fluid goes into the cylinders, and erection can be achieved. And, this is actually probably the most effective of all the treatments that we've discussed, because it pretty much works all the time. I mean, unless there's some very rare instance of a mechanical dysfunction, very early in the use of the implant, when patients get these implants, they pump them up and they work. And so that dependability, that reliability has led to a very high reported satisfaction rate. And this satisfaction rate is reported in the literature with well over 95 to 98% of patients and their partners being happy with the results. So this is that little illustration I just wanted to show you. I think it's better to see it. I'm pretty visual. I think most guys are visual. So instead of me describing it, you can kind of see how this works. So on the outside, nobody really knows that you have it. All the parts and components are on the inside. And as you can see, the patient is squeezing and releasing the pump, and that is moving fluid into the cylinders. And so that process continues until the erection is achieved. And then when the patient and their partner are complete, they push the deflation button, and that fluid leaves the cylinders and then goes back into the reservoir for the next time the patient and their partner want to be sexually active. So as you can imagine, that gives you complete control over when sexual activity happens, how long that erection lasts for. It's in your body, so anywhere you're at, wherever you travel, you can be spontaneous. And so those are some obvious upsides. But before we get more into the ups and downs, what's it like to have one of these put in? I mean, it is a procedure, obviously. So patients have a little bit of anesthesia, and it's an outpatient, go home the same day type of procedure. A very small incision at the top of the scrotum, kind of near where the penis and scrotum come together. Small incision to put this in, and go home the same day. I always leave just for one day, just a urinary catheter in a drain and a gauze wrap around the penis to prevent bruising and swelling. You come back to the office the day after to have that removed. And then usually about 7 to 10 days for the swelling, soreness, bruising to settle down. But also usually within about 7 to 10 days, patients have resumed their normal routine daily activities. So there's not a huge recovery there. And then obviously a little bit longer before sexual activity can take place. And usually that's between 4 to 6 weeks. So we talked about some of these benefits already, a very high satisfaction rate, 97, 98% of patients and their partners. A lot of insurance plans do cover this. Certainly Medicare, VA, TRICARE, and many of the other commercial carriers do, depending on the plan, of course, but many of those plans do have some coverage. These devices provide a long-lasting result. And I tell patients typically 10 to 15 years is where I see most patients ending up with the longevity of these implants. Now, of course, there's occasional fellow that'll come in at year 7 or 8, but I've had guys come in 16, 18, 19 years later. And so generally speaking, they have a pretty good durability. And, it just allows you to be a little bit more natural. I mean, this device is on the inside of your body, and outwardly, unless someone's feeling you, but just looking at you, people don't really notice that you have it. It does not interfere or alter your ability to reach an orgasm or achieve climax. And like I said, it allows you to be spontaneous with your partner. Obviously, it's a procedure, so there are potential risks or complications that could take place. And I think the most obvious one is infection. Any device that goes in the human body, whether it's a pacemaker or a knee implant or hip implant, anything has a risk of infection. And typically in men who do not have diabetes, that risk is about 1%, or in men with diabetes, that risk is a little bit higher at 2%. But in either scenario, 98% or more of patients do not get infections. But that is an important consideration. Certainly, mechanically, these devices wear out and when they wear out or break down, they have to be replaced. And so an infection or mechanical issue does require a second procedure to go through the scrotum to have that device fixed or removed and replaced. These implants are not something that you can just take out and go back to the way that you used to be. So I'm always a little bit cautious when a patient comes in and has really never tried any type of therapy for erectile dysfunction and just immediately wants an implant. I typically feel much more comfortable with someone a patient having tried at least something to make sure that they're pretty happy with their decision. But by and large, the risks are generally low across the board, and so it's not a major risk surgery to have done. So in summary, erectile dysfunction is common. A lot of men have it. About half of men over age 40. Thankfully, there's a lot of treatment options that are available, and of all those treatment options, when you consider all of them together, the implants have the longest lasting and most satisfactory result. So a good website, and I see there's a lot of questions popping up. We're going to address all these questions at the end. Mike is taking note of them, and we'll go through them one by one. But if you have other questions or want to do some research further on your own, there's a good website called edcure.org where you can get some more of this information as well. So we'll spend the next 10 minutes or so, or maybe less, talking about stress urinary incontinence, another big men's health issue. So stress urinary incontinence is essentially the unwanted leakage of urine with physical movement, typically coughing, sneezing, laughing, standing up from a seated position to standing. And so you can't control it. The urine, when your bladder starts to fill up, the urine just comes out. It's not terribly common. About 500,000 men worldwide suffer from this. And in most cases, it's a side effect of surgery, which we'll look into more here in a moment. But just like we did with erections, it's important to understand, how do we normally urinate? And as our body produces urine, it's collected and stored in the bladder until our bladder reaches a certain degree of being full, and you feel like you need to go urinate. So when you go to the bathroom and you urinate, the bladder relaxes, the external sphincter, which is this muscle here below the prostate. So you have bladder, prostate, external sphincter. That muscle relaxes and urine flows. And then once the bladder is empty, this external muscle here goes back to contracting, so that your bladder can then fill up with urine once again. So causes of stress incontinence, we talked about this a little bit, is predominantly surgery, prostate cancer surgery, but rectal cancer surgery, colon cancer surgery. I've definitely seen that in those patient populations. But you can also get it from radiation therapy for prostate cancer or colon cancer or rectal cancer. You can have it from trauma, car accidents, motorcycle accidents, things like that. So there's many things that can lead to development of stress urinary incontinence. And just like erectile dysfunction, and I would argue probably to a stronger degree, there's a very negative effect on quality of life in men who have urinary incontinence. At least isolation, depression, poor self-esteem, makes it difficult to engage in relationships. So it's a very important issue to address if this is something that is affecting you. So let's drill down just a little bit more on stress incontinence and prostate cancer treatment. And really this picture, I think, says it all. So you have your bladder, you have your prostate in the middle, and then as the prostate transitions into the urethra, you have the urethral sphincter right there. And these yellow lines that kind of wrap around the prostate are the nerves that control both blood flow into and out of the penis for an erection, but also controls the muscles that allow contraction of the urethral sphincter in the pelvic floor to allow you to hold onto your urine. And so if you were to surgically remove the prostate, those nerves can be disrupted. But likewise, if you radiate the prostate, those nerves are disrupted or damaged from the radiation as well. And in either scenario, it can lead to the urethral sphincter not functioning as well as it should. So if you're a patient that has this type of urinary incontinence, what can you do? And really, you can do the simple sort of short-term solutions, which are don't drink very much. The less fluid you drink, the less you have to urinate. And that's not great for your kidney health, but that's what some people do. You can wear pads, you can wear diapers or Depends. You can wear little penile clamps that will clamp the penis and prevent urine leakage. You can do physical therapy and learn how to do Kegel exercises and achieve better control of the muscles of the pelvic floor. And for some patients, that can be very effective. And I always encourage patients to give that a try because if it works, it's great. It's something you can do on your own, and it's not anything more invasive than just exercising. But if these short-term options are not something the patient is interested in, or they're not being very effective, then there are two procedural options that could be considered. The first is the male Sling system. And kind of similar to women, the Sling for men is basically a mesh material that functions as a hammock that kind of wraps underneath and supports the urethra up towards the body, and thereby increases the resistance in the urethra and can reduce the leakage. And so it's nice because, basically you just continue to urinate the way that you always have, and that Sling is there working to your benefit. So really it's undetectable to others because the Sling is obviously down deep on the inside. And there's a pretty high success rate, and I'd say, about 90, and we have it there on the screen, 92% of patients would undergo the treatment again. So a lot of patients are happy with it. But I think it's absolutely critical to understand that not all men with stress urinary incontinence are good candidates for this procedure. And really, to be a good candidate for a Sling, to have this optimal outcome, your leakage has to be sort of on the minimal to mild end of the spectrum. And you have to have good control of your urinary sphincter, meaning you still have the nerves are still intact enough to where you can control the sphincter and you have some function from your sphincter. It's just your sphincter is not quite strong enough and a little bit of urine sneaks through. So for the right patient, the Sling can be a good option. But what's considered to be essentially the gold standard treatment is the artificial urinary sphincter. And I say it's the gold standard treatment because it really can be used for anyone. It doesn't matter what caused the type of stress urinary incontinence, whether it was surgery or radiation, et cetera. It can be used for any of those patients. It is also undetectable to others. And we'll show you some pictures in a moment that make that a bit more apparent. But it functions just almost exactly like your natural muscular sphincter. This device is compressing your urethra 24/7 until it's time for you to go to the bathroom, and you can control it when you want to. And so as you see in the picture here, there is a cuff around the urethra, and you see that in the middle, and that cuff is consistently compressing the urethra to prevent the flow of urine. And then there's a control pump down in the scrotum that when you feel like you need to go to the bathroom, you squeeze that control pump, and that allows the cuff to open, urine will flow, and then it'll sort of automatically reset itself. So this is another video similar to the penile implant that explains that. And remember, on the outside, if someone were to look at you, it's not very obvious that you would have this. And so you see the different components there, and the patient feels like they need to go to the bathroom, so they squeeze the control pump, the cuff opens and urine flows, and the bladder is able to empty. But after about 90 seconds to 2 minutes, that fluid flows back through the system, goes back into the cuff, and the cuff starts compressing the urethra yet again, and it prevents the flow of urine to allow the bladder to fill until the next time the patient needs to go to the bathroom. So to have a urinary sphincter device, it's also a come in, go home, same day type of procedure under anesthesia. It typically requires 2 very small incisions, one down at the very bottom, kind of below the scrotum, and what we call the perineum. I'm not sure how many people know what that is. And the other small incisions on the lower part of the abdomen. And usually within 7 to 10 days, these patients are also back to routine, normal daily activities. And around 4 to 6 weeks, you'll see me in the office, and we'll work on getting that working for you. Again, patients are very happy with these devices. Anywhere from 90 to 94% of patients would have the surgery done again or refer or recommend it to a friend. And these devices, similar to the penile implants, have a good longevity in terms of mechanical durability and ability to provide that for you. And I think the big thing with both the urinary sphincter device and the sling is it kind of puts you back in control. And that's, from what men tell me, is the most depressing and frustrating aspect of stress incontinence is you don't have control and you're sort of subjected to this condition. And so getting back in control is important. So in summary, treatment options put you back in control. You can urinate when you choose to urinate. The parts and components are all on the inside of the body, and it gives you some sense of normalcy and confidence. Potential downsides, obviously, each one is a procedure. And specific to the male sling, the sling can be a bit tight. And unfortunately, I've not seen this firsthand, but there are reports of patients where the sling is so tight that they cannot urinate at all. And so a catheter has to be put in for a period of time. And in some cases, you have to go back and basically cut the sling and open it up. But so urinary retention is a unique side effect to the sling. Eventually it can loosen, as the patient gets older, and or if the patient gains weight, the sling can get a bit loose and not have as good of an effect at controlling urine. In regards to the urinary sphincter device, this is more mechanical. So obviously the mechanical aspect of it can fail at some point and it no longer works the way that it did originally. The cuff, as it compresses the urethra, it's compressing that urethra most hours of the day. That the area where the cuff compresses the urethra can shrink a little bit, what we call atrophy, or in rare cases, the cuff can completely erode through the urethra, which is obviously not a good thing and will require a procedure to correct. But as I said as well, that thankfully that's very rare, very rare issue to have. So, in summary, stress urinary incontinence is certainly nowhere near as common as erectile dysfunction, but for the men that it affects, it's very significant and has a very negative impact on quality of life. And there's a variety of short-term, temporary solutions or long-term solutions, such as the male sling or the urinary sphincter device, that are available. And so, similar, there's a good website with additional information and resources, fixincontinence.com, that you can visit and do a little bit more research on your own time if you're interested. But at this point, I'd like to stop talking. You're probably tired of hearing me talking anyways. Let's get some questions. I think we've had a few people submitting questions.